So most of these slides are actually come off what's on the website for the ENET Centre of Excellence. I've attended the course twice. Dale's attended it, and so has Paul Roche, and we have good and so I think is Susie and Vanessa from Sydney Vital. So we have some pretty good insight into what's involved, at least on paper. But what we've heard in discussing with Peter Mack is the process is quite laborious and established. So from the history, this is ENET's Centre of Excellence, and this was established in around 2007, 2008. Is that right, yeah. Shel? And at that time, it arose from an investigation or a task force to look at the feasibility of establishing Centre of Excellence. And the purpose really was to try to allow NET patients to seek specialists who offer the best treatment, to standardise and offer a high level of care with consistent platforms, standard operating procedures, and give some sort of uniformity of that high level care across Europe. And so if I said, look, what is it really about? It's really, I think, about defining excellence and establishing a set of standards that need to be upheld in order to achieve the status of the title that is attributed to the centre when it achieves it. So this is a map off the website. There may be more than 37, but that's what the website says. So these are the sites all over the place that have been appointed as centres of excellence.
Just a comment, you can see that Spain, they have no centre at the moment.
Yeah, no, I saw one in Greece too. I thought that was interesting. But we didn't know what was happening. Is that Portugal off the end there? Is it?
Portugal and Spain, they have no centres. But they are applying now.
They're applying now, okay. So the criteria is you can apply as a centre or as a network consisting of up to 3 collaborating hospitals or locations. On the website, the physical distance should be with less than 50 k's or 45 minutes drive so as to make the collaboration meaningful. Again, this has been established, these rules have been established for the European environment. And I guess at the end of this talk, I'll ask Shel some questions about the Australian context, and I'll introduce some concepts there for us too. You know, these rules have been established in a different environment. Are they necessarily the same? Do we change any of them for the Australian context? You can also have centres outside of these limits considered as affiliated partners. So they're not part of the group, because part of it is they have to, if you're going to be a centre, you have to be subject to audit. So if you're not able to be audited as part of the centre, then you can be an affiliated or a collaborative centre, but you're not subject to a separate audit. Now, you need to see at least 80 new GEP-NET patients per year. These are the criteria. Loosely, I'm not putting all of them down, but generally speaking, you need to demonstrate a timely patient review and liaison with referrers, and that's got to include documentation back to the referrers. You have to have a NET MDT/tumour board with broad representation, and something was brought up earlier as who needs to be an MDT. I'll show you what the bar is for a centre of excellence. You need to have broad specialty representation and expertise, including an attendance log and a minimum participation of 1 representative from each craft group that attends the meeting. Research and trials are obviously an essential part of the centre as a whole. Standard operating procedures for your treatments. So this is the criteria list, of which if you go online, you download the paperwork, there's a big section on each of it. So organisational structure, defining who the core partners are. The communication, the MDT, requires a tumour board, management meetings, Q&A around that, and ability to interface transfer of communication electronically. It's the consultation. You need to have defined settings, and this will vary. I mean, even in our own hub and in our own campus, there are different places for consultation. So we have to see how that fits in within the model, but it's perhaps more about demonstrating that we can fulfil the other criteria to accept that ours is a bit different. You need to have performance data, Q&A, and then in terms of each of the subspecialties, so endocrinology, gastroenterology, medical oncology, pathology, radiology, nuclear medicine, surgery. Notice radiation oncology is not there, Andrew, but we'll allow you to slip in, is that right? And surgery, scientific activities, Patient involvement's interesting. I don't think that's necessarily at the tumour board level, but rather in how you engage the patients within the network. I don't see nurse coordinator there, but I presume that comes in under the organisational structure. And then it's the key bit is at the bottom, there's a follow-up and tumour documentation. Interesting talking to Stephen Begbie earlier about the type of communication he's received from other places that he's had patients referred to. And we know that even the Peter MacCallum Institute had to look at their structures for all of this in fulfilling the criteria. So if you're going to apply, you have to have this in place. Now, we discussed this a couple of years ago. One of the things we've lacked in our environment is actually having a committed pathologist who attends every meeting. Now we've actually achieved that, but you can't apply without having that infrastructure in place. We've got around it by discussing the colorectal path in the colorectal meeting and the other meetings where the pathologists do attend. You don't have a thoracic physician here. You don't necessarily have to discuss your thoracic cases here because this is about the GEPNet. But if you have another meeting where that can be discussed, then that patient should be discussed there and then put into this meeting. And then you do this, and that every process, every step of the way has to be auditable. We have a separate MDT of the gastroenterologists participate. We have a different culture in Australia, Shell, to Europe. Many of the gastroenterologists in Europe are actually oncologists as well. Whereas here, a lot of them are procedural and therefore rarely participate in our therapeutic discussions, rather in the diagnostic discussions. So I'd be curious to know how Peter Mac fulfilled that criteria. So if you want to apply, you apply in April 30. The audit is the following year. It gives you about a 12 to 18-month lag time to prepare. The accreditation is of the whole centre and is an independent auditors team that's co-opted by ENETS. They have a group. I think you've changed who you use recently, but...
We have a new agency.
Yeah. There's a cost to do that. You have to cover the costs of the auditor travels. And you need to have all the documentation prepared. So if you're going to prepare for this, we've discussed this, you need an admin officer to at least ensure that you have everything ready and in place. And if we are to apply next year, we've almost got to start now to have things prepared. So Peter MacCallum's the first overseas pilot site to apply. They've completed their audit after about 18 months preparation, and they're anticipating the outcome announcement in the near future. So this is off the website, and I've made some comments of my own, and we can at the end discuss why we would be interested in this as a community in Australia and perhaps why we wouldn't. What's the benefit to the centres? ENET says, well, you'll have better recognition, both in-house and external. You'll get more patients, therefore that'll improve the throughput and volume. It improves by establishing structures. You perpetuate the quality of those. You improve the MDT meetings. And when I've participated in the Royal Free, actually Eva and I, net MDT, and it was interesting to see how that was set up. And when we came back and we set ours up, what we haven't been able to do is get the infrastructure support from the organisation to be able to do it. But they have 3 hubs. The pathologist, the nuclear physician and the radiologist have their own computer, 3 different screens. Each one just goes straight to their screen. It's much more efficient. And the letters are dictated real time at the end of the meeting. So it could be an hour, 2-hour meeting, but it's all done and you walk out and it's taken care of. Except they don't do nuclear imaging and don't spend anywhere near the amount of time that you spend, Liz, preparing. The documentation I mentioned, patient follow-up, you have to look and see whether the recommendations are pursued. If so, why? If not, why not? More from the point of view of quality assurance and seeing there may be good reasons for that. In our institution, the person whose job it is to ultimately do the treatment is the person who brought the case to the MDT. If it's the oncologist, who's generally it is, then you go back and discuss the outcomes of the MDT with the patient and see if they agree to pursue the treatment. Research and participation in trials, one follows. The more patients you get, the better you can contribute to that. Peer group discussion, I think, is an important thing. You do elevate the expertise of all of the contributing subspecialties that are there as you start to see more cases. And then I guess if you have an affiliated referral partner, that enhances that centre as well. One of the things I brought at the bottom and made a point is there's a cart and a horse effect here. If you aspire to be a centre of excellence, it forces you to elevate your standard in order to do it. And then you've got to uphold the standard in order to keep it. And in our institution, one of the reasons why we're strongly aiming to do it is for that very reason. There are gaps we've recognised in what we do, and the only way to fill them is to actually do this to fill those gaps. What's the benefit to the patients? Well, it's not defined on the benefit on the website, but anticipated benefits are suggested in a broad variety of areas. In the Australian context, I think it's about centralising multidisciplinary expertise and improving the patient journey that John Layden mentioned as well with the net nurse coordinator, using the surgical expertise, particularly for some of the subgroups where you need that. For example, our institution is very strong in pancreatic surgery as well as colorectal. Using the expertise in other areas such as theranostics and path review. Interventional radiology, another one of our unit strengths. Clinical trials, access to trials. If you have the volume, you're more likely to attract or be attractive to a CRO or a third party for a clinical trial. Our MDT does now involve video conferencing. We can actually engage people from out of area to participate themselves. When the system breaks down, we just use the iPhone on loud, and you can hear that. Faster referrals, and that's part of the process for us, expediting the referrals largely through our nurse coordinator. We have a public campus mix, so patients will be seen either in the public facility or the private facility, depending on where the bed is and their capability. The clinicians involved, as they get more experience themselves, get better at their management of patients, so that has a downstream effect on patient care. The engagement of all the doctors interacting better for the patient to know that you're doing that in the forum rather than ringing each other up at 5 different occasions separately and not having a common documentation of that process, and less treatment delays. These are just a list of some things I've mentioned. But we do have challenges in the Australian context, geography being one, large landmass concentrated to coastal populations. We're a small country relative to Europe in terms of population. We also have a different health structure. We have mixed public-private, state versus federal health model. We have a confusing who pays what system a user pays. And to give an example, so we have a situation of 5-6 years ago, the government gave several $1 million to create ANSTO to make lutate pre the NETA-1 study. But wasn't willing to provide funds to support clinical trials, but did establish a prospective protocol observational study, which is what we did through Cancer Institute to gain evidence. The LHCs, even within the same part of, in the same city like Sydney, different local health districts will have different and diverse platforms. I go to Armidale, northwestern New South Wales. That puts me in under the Hunter New England Area Health Service, no longer under ours. Our MDT involves cases from all sectors, private, public, and all different LHDs. In the Royal Free Hospital that we went to, it's the NHS. And then they use all the imaging's accessible for wherever you're from, just on one system. We have the issues of privacy laws prohibiting us from getting easy online access, and it takes 10 minutes usually to load up a disk from somewhere else. So that's a bit of background on problems. This is the Australia versus Europe model, and I was interested here, they've left out, as you can see, Sweden there, Shell, but I found another one that had put Sweden in there. But this demonstrates the size of our landmass and how most of our landmass actually isn't used at all. This is where we fit, if you actually see how we fit in terms of the water space that's in Europe as well. So we do have, the geography issue is a big one for us, and it's probably something that perhaps the COE model was not originally, you've got to be 50 kilometres from, was designed in a different setting. So why should we do it in Australia? I think to elevate the bar for clinical excellence, to facilitate the peer review audit process, to engage referrers in the interaction, to ensure active MDT member participation, to enhance our trial opportunities. We were lucky to get the PDR 001 trial. That closed pretty quickly, actually, but this demonstrates there's a lot of interest in clinical trials. And but again, drawing that attractiveness for Australia as a site. For training, we've had 2 NET fellows come through our group. One of whom went on to work, David Chan, to work with over at Sunnybrook with Simran Singh, and the other one went to work with at the Royal Free. She's there at the moment. And David's come back to finish a PhD, and we've got another one. So that's the kind of thing that if you're a centre of expertise, we're not a centre of excellence, we're a centre of expertise, being an excellent centre enhances that. And I think it'll also enhance funding opportunities. I think you can't lobby to fill those gaps unless you have strength. And certainly we have the capacity to have better links, even within ourselves. I put North Coast, Hunter, New England, possibly Auckland with Ben Lawrence, particularly with the tissue collecting. So these are the kinds of opportunities that are out there for us for doing it. I thought about it. If I was a patient, why would I want to go to a centre of excellence? I think one, because once you know it's a centre of excellence, once you understand and it's available on the website what it's about, then you elevate your own expectations of your clinical care. You expect that you're going to timely diagnose if you haven't got one, or you get an accurate diagnosis to start with. You get access to a variety of therapies, high quality empathic care. Not that this isn't happening elsewhere, but it's about concentrating it. And setting standards that would be applicable for all the collegiate organisations. The Unicorn Foundation website carries the following statement. Being diagnosed with cancer is a very scary and confronting experience. Being diagnosed with neuroendocrine, sometimes called carcinoma cancer, is even more confusing and daunting due to the lack of information and resources readily available. John would say that still exists in many parts of Australia today. So the New South Wales context for COE, there are two main centres for luteate, St George Hospital and RNSH. I can't spell it, even though I work there. Multiple centres offering nuclear imaging across the state. So imaging's been available in a variety of centres, but theranostics hasn't. Surgery is not centralised, but caseload varies. So we have a high volume pancreatic and colorectal centre where we are. So our midgut and PNET calibre of surgery is very high. And there is discussion around the traps, particularly with complex surgery like Whipple's, whether that should be centralised to centres of expertise. And we certainly are a net centre. We get cases from ACT, North Coast, Hunter, New England, other areas in Sydney. And these are some examples of our recent trials. Control nets will hopefully finish soon. We've actually enrolled a patient on COMPETE, so that'll be our main PRT trial. We finished the telotristat trial and we finished participation. The PDR 001 was done in the private facility. So what are our plans? We are looking at ticking the boxes first and anticipating submission next year for the pursuit of it. We have to decide amongst ourselves on this concept of affiliated centres. Certainly, there are centres that refer strongly to us. That would strengthen that relationship. We formally appointed a pathologist. We need to get an admin officer, and the bottom list is the things that we need to make sure we tick the box. Our challenges are funding. We've had some seed funding from pharma to set up some of the things that we've lacked. Our nurse coordinator, for example, is funded from 3 different sources, and that's not permanent or perpetual funding. We have issues with systems, the database, so we're very lucky that Dales was able to set up our database through RedCap. I'm not sure how that would be acceptable in the audit process, but we need time to audit. We need to establish expectations amongst our team. They don't even know. Well, I asked you to stay, Andrew, so you knew what you're up for, okay? But I don't even know that they know that we want to do this and that what it's going to create for us. So I thought I'd end there. I don't know that many of you actually knew what this was, but I thought it was an opportunity to ask some questions, perhaps pick Shell's brain on this because he's been involved in the whole process from the get-go.
Yeah, I was really involved from the very start of this adventure, and I'm also an auditor, so I know the shortcomings. And so the important thing is that you organize the MDT very carefully. And I heard some discussions about that the surgeons didn't want to participate. If that is true, then you will not pass. They must be there, and they must fill out the log. I have seen in some centers that the surgeons are not coming regularly to these tumor boards. That is not okay. So that is something you have to think about. The other thing is that you should have a database, because the aim in the final end is that we should link together all the centers of excellence and get the data out and make some evaluation of the value of these centers. And also something that is important is that your pathologist is also there. And as you said, the setup at the Royal Free is the same as with our setup in Uppsala, that you have different screens with the nuclear medicine person, the radiologist, the pathologist, and they show at the same time all the data we need to make a decision. And the pathologist should also give you the reply of the specimens you send to him within 1 week. Sometimes you had to wait up to almost 30 days to get the data from the pathologist because there are shortness of pathologists, but that is also something. And you had also to come up with CVs for all the members of the MDT. So these are some essentials.
I'll get Stephen first. Thank you, Giselle.
So at the risk of becoming like Dr. Vogel New York, couple of questions. For numbers, would you have to combine with St George?
No, I think we make the numbers without St George.
Okay. Had you thought about using the expertise of Europe and forming ANETs and doing the same thing for Australasia, but not going the whole European affiliation route? And the other thing is, are you paying a facility fee for your Medicare item numbers for MDTs to pay for some of your admin work? Because that's quite a reasonable way, we think, of paying for the necessary administration.
So when we first looked at this a few years ago, we wondered of the applicability of the whole structure to the Australian setting. But then as we thought more about it, we thought that the positives outweighed the negatives in terms of what it does to elevate the standard of care. That I think if you strive for that, then striving for a C of E is something that you should aim for. And I do agree that we are a completely different context, and I worry about how we will fulfil or how we will be received by an auditor. But we haven't looked at the nitty-gritty of what's going to be audited. I mean, you lay on the table up front geographic issues and all that sort of stuff, and we're very different. And that has to be acknowledged if we're going to be applying. I don't know.
We take that.
Yeah, you take that into consideration. So, but I think ultimately for us it was around a case of the horse versus cart phenomenon. If we want to be a centre of excellence and we're not going to tick the box in these areas, then only by striving for it we're going to tick those boxes. So that's what we decided in the end. Secondly, on funding, I'm not sure what we do with that. We should build for our MDT, but I'm not sure that actually generates as much money as you think.
If there's 100, so if there's 10 doctors, 20% brings you to about $1,000 for a meeting. So that actually gets you a decent chunk of an administrative officer.
Well, we should have a look at what I haven't looked at the numbers. We do, but I don't know who takes care of the numbers. We'll see who does. Yeah, we were just talking about how we have to get rid of all our money at the end of the financial year to the bottom line. So
along the same lines, I mean, it is something that Comnets could think about, because Canada, if you overlay the map of Canada and Australia, they're very similar.
They're very similar.
And I think we could adapt the ENETs. We could undercut them in price, Shell. But, make it something more appropriate. For example, the distance thing is not very appropriate because not many hospitals are so close to other hospitals in Australia. So if there is interest, then it is something that we could do at Comnets and have our own criteria modified, appropriate for the geography and appropriate for the scenario.
Yeah, I agree entirely, Eva. We thought we'd wait and see how Peter Mac goes, so they may fail, and then we might have to reconsider. Dale first.
Can I just respond to Eva, because I think one thing that Comnets has taught us is that the practices in Canada, New Zealand and Australia are polar opposites. We just have very little in common with the Canadians when it comes to PRRT and the imaging side of things. So I think it'd be really difficult. Also, we'd be a smaller number. Conversely, when we talk to the European colleagues, almost serendipitously, we find that we're using identical protocols and treatment regimes and amounts that we're using, and the approaches are very, very similar. And we had some Finns visit after the World Congress to come to North Shore, and we do like imaging at exactly the same time points and things. So I think also Cheryl's last point about perhaps one day linking all the data up argues to go in with the same group. You know, I think we feel in nuclear medicine very comfortable that we are very much practicing in the European style rather than, say, a North American style.
I can just comment that Toronto had asked for accreditation, so we are interested.
Bill?
But it's important not to turn accreditation into a feel-good exercise. I mean, the whole point of it is to lift the bar, and if having sort of, 3 centres thousands of kilometres apart all teamed up and getting some badge which makes everyone feel great, but in fact they're not doing anything to improve their service delivery, then it's a hollow sort of exercise. There's plenty of research around which shows that patients treated in research centres, patients with cancer in general, treated in research centres have better outcomes than those not. Is there anything in relation to NETS patients, even if it's psychosocial outcomes, that would be useful to persuade, I'm thinking of my hard-nosed administrators, that would be useful to persuade them that this is an exercise worth going through?
Michelle might be able to answer that for us. Thanks.
What we are doing just now in ENETS is that we look at the data from the first 6 centers that were established in 2007 for centers of excellence, and so it's now 10 years since we started. And my personal feeling, without going through the data, we can say that we have significantly improved the outcome for the patients with the neuroendocrine tumors. And also what we realized, we were thinking that we had very good standard operation procedures when we went into this. But when we started to look what is really missing, we could improve significantly also the standard operation procedures.
Yeah, just to make a point back, Bill, to yourself, we've been interested in NETS for a long time. This isn't the start of it for us. We've been doing research activities for a long time, largely through the theranostics, through our translational research unit. So it's really about tying up some of the loose ends for us in the clinical arm that we felt that were disadvantaging us.
But, the sooner there is some abstract or a publication which attests to improved outcomes, the better, because that's what will change the financial controllers' minds.
I think they will come. First the tests go down.
So I didn't present this earlier when I presented the control nets trial, but one of the things we learnt in setting up that trial was how non-standard things were being delivered across the various centres. And actually the process of the control nets trial established a manual of some sort of degree of standardisation. Not everything's the same across every centre, but that exercise in itself was extremely valuable. Yeah.